Good afternoon, everyone, and welcome to G60. That's a short form of 60 minutes for glaucoma. And as you know, we've strived to get some great people to talk to us and to transfer the knowledge that they've accumulated over several years of being passionate in their area of work. And today we're very pleased to have with us Dr. Keith Barton, who is from Moorfields Eye Hospital, and he will speak to us about his experience with glaucoma implants. But I'm going to leave the introduction of Professor Dr. Keith Barton to Dr. Surinder Pandav. Dr. Surinder Pandav, as you know, is the Chief of Glaucoma Services at PGI in Chandigarh, and we're very honored to have him here with us. He's recently taken over as President of the Glaucoma Society of India. So very good to have you with us, Doctor. And I'd like to invite Dr. Surinder Pandav to introduce Dr. Keith Barton to us.
Thank you, Vinay. It's a pleasure to be part of this program, and we are especially honored, Dr. Keith Barton, that you spared time for us. And we know you have very large commitments to the science and to the community, and finding time must be hard for you. But thank you very much for joining us today, this afternoon here in India. And I'm sure our viewers are going to be benefited by your experience and your knowledge. For the sake of our listeners, I'll have a brief introduction of Keith Barton. He's a consultant ophthalmologist and glaucoma specialist at Moorfields Eye Hospital, and honorary reader in UCL Institute of Ophthalmology. And he co-chaired the ophthalmology of Future Forums. I think he's a platform which he created some time ago, and that's meant to be an interface between the researchers, ophthalmologists, and the industry. I can say it's a great initiative, in fact. He's also editor-in-chief of the British Journal of Ophthalmology, and we all know how prestigious that post is. So he is very much interested in surgical management of glaucoma, especially the tubes, the implants, and particularly in difficult situations like uveitis. He is a very well-known researcher, has been part of many international collaboration studies like TVT study, the PTVT study, and also ABC study. And he was in the managerial committee for the the TEGS study. There's an advanced glaucoma intervention study, and also treatment study, and also the ocular hypertension, the lasers in ocular hypertension, the light study, which we have seen in recent publications. We all know that these studies have actually given us a lot of information, knowledge, and framework to how we treat these patients and how we deal with different situations, and how we understand better about these technologies and these techniques. Keith has been invited to lecture in almost all continents of this world, and he was also a recipient of Sharmis Medal, which is a great honor for his surgical work, and is offered by the societies, I think different European ophthalmological societies. He is also treasurer of the International Society for Glaucoma Surgery, and also founder of the ESCRS Glaucoma Day. He has organized several glaucoma education symposia at the Moorfields Eye Hospitals, and not only there, but actually in many countries in different ways. He has been listed as one of the most influential glaucoma ophthalmologist by the magazine, the Ophthalmologist magazine, and that's actually is a great honor. And last year, I think he was placed in the first 10 positions. So that's a wonderful. I think we have a great ophthalmologist with us today. Dr. Barton is actively involved in surgical teaching and training and he runs many educational programs in London and as well as in other countries through the International Society for Glaucoma Surgery. I think he's involved in one of the office bearers of that society as well. He's not only a great ophthalmologist, surgeon, or a scientist. He's also a great social worker, I would say. He has done a lot of charitable work, and many population-based studies he has done in South Africa, in Ghana, and also he has been part of TEMA eye study there. He regularly takes, he's a very avid cyclist, and you'll be kind of a surprise to know that he cycled from London to Paris. That's like 200 miles, within 24 hours, and he has done it 3 times. And the idea behind was basic to raise funds for the International Glaucoma Association, and he collected whopping $74,000 between 2030 and 2070. That's remarkable. I think that's a wonderful thing to do, and we can all take inspiration from what he has been doing and what he continues to do. So Keith, we are very very honored and very fortunate that you are with us today afternoon, and we are all looking forward to listen from you and learn from your experiences. And I'm sure all viewers are going to be delighted at the end of the same class. Thank you, Keith, once again for being with us, and I hand over the session to you. Thank you.
Thank you very much. Can you see my screen?
Yes.
Yes.
And you can hear me. You can hear me and see my screen, I hope.
Yes. Yes.
Thank you very much for the very kind introduction. It'll always be a pleasure to come to India. I'm sad I cannot be there, but this is a good way of interacting. My understanding from previous visits to India is that not that many people do tube surgery. Although I know with the the Aravant implant, the ADI, which I'm not actually going to talk about, that probably that might be changing. But my glaucoma practice is very surgical, and I was once told by one of the residents that I had a very skewed view of glaucoma because my practice is very surgical. I work with a lot of the companies, but from tube point of view, from implant point of view, in the start there was a Multino. Well, it wasn't the very start, but the recent start in the 1960s and 70s with the Multino, which was a permanent hole in the eye that couldn't close. But it was more than that. Multino took the aqueous away to the equator of the eye, where fibroblasts are less active than at the limbus, and in theory, scarring would be less. There's also a plate to prevent external obstruction, and the idea was that predetermined the bleb surface area. And so there are really 3 key factors that made implants work to some degree: the permanent tube, the equatorial drainage, and the plate which predetermined the bleb surface area. However, of course, it wasn't as simple as that. There was a high risk of complications. It was very hard to control the flow early on, even though you've got plumbing and a pipe, and you should be able to regulate that. It was difficult to regulate, and long-term pressure control was not very good. And people used to always say that you had a very high risk of early complications, but at the end of it all, a successful tube was a pressure of 23 on pilocarpine and timolol. So they really weren't that effective. Where are we now? We're now in an era with thousands of different implants. Well, not thousands, but many, and many are appearing all the time. And these, of course, are completely different from the implants that I've been going to talk about. And in fact, these are really not alternatives at all to the type of implants I'm talking about. But these are for very mild glaucoma, moderate, where even a trabeculectomy might not be required. So why do we need the bigger implants, the serious ones? Trabeculectomy, as you know, in India, is a good operation. It's stuck around for 50 years simply because it's cheap to do and it works. And the efficacy is indisputed. With the appropriate case selection, trabeculectomies will lower the IOP for much longer than any alternative. And that's been well shown in these TRAB versus medication studies, the Moorfields primary treatment trial, the collaborative initial glaucoma treatment trial. Trabeculectomy worked more than medication throughout. So why then really do we need implants? Well, this 20-year retrospective study from Cambridge, where trabeculectomy really started, showed that trabeculectomy success, yes, overall it is very successful, but it's highly dependent on glaucoma diagnosis, patient age, previous surgery, And if you've got patients such as these in the 5FU filtering surgery study who are at high risk of surgical failure from scarring or secondary glaucoma, then TRABs really had a poor chance of success, slightly more than 20% chance of success if no 5FU, and about 40% chance of success with 5FU. So although TRABs work very, very well in certain groups, case selection is absolutely critical. And there are many situations where trabeculectomy will either not work nor will not be feasible. In such situations, we really have only shunts or drainage implants as a practical alternative. And these work in very wide-ranging situations that people would often not consider even doing surgery in. And I've jokingly called these situations sort of the untrappable. There is, of course, no such word. This patient has a huge nasal bleb, and this was a situation where I think further trabeculectomy would either be impossible or not work. This patient has 3 previous trabeculectomies. There's 1, 2, 3 in a row. A 4th trabeculectomy offers no logical chance of working. You know, he who ignores history is doomed to repeat it. And but on the other hand, in these cases, you can often logistically fit a tube in between the Himalayas here, in between the blebs. You can fit tubes in even in these scleral buccal cases, which we see less commonly nowadays, but in whom trabeculectomy really has no chance of success, simply because of the amount of scarring. And even though the Barvelt, which is a large plate, is a big plate to put in the eye, it still works. It still can be, because of its low profile but large surface area, its low profile, it means you can fit it in all sorts of places around the eye. And here I cut a segment out of the buccal, which had been there many years, and you can see the Barvelt in place. Or here with a low-lying 276 buccal, the low-lying Barvelt can go over the top and still not be a highly elevated bleb. And you can stitch it to the capsule of the buccal. You can stitch it to the plastic of the buccal. There's all sorts of ways. Patients with pemphigoid or activated conjunctiva, where again trabeculectomy's got no chance of success. And you might think, due to the restricted motion, that it might be impossible to do any sort of surgery. If you open up the conjunctiva, you often can get quite good mobility. And in patients with pemphigoid, you have to ensure that the patient's on adequate immunosuppression. And these patients would all come from my colleague, John Dart, who's since retired, who would have controlled them all with whatever drugs were required before I put the tubes in. Patients with silicone oil, often I wouldn't tube someone who's got an eye full of silicone oil, but after the oil's removed, there's often some left. And again, trabeculectomy has a poor chance of success in these eyes. There are eyes where you couldn't even do a diode. You might say, well, why not do a diode in those cases? I find tubes produce more definitive pressure control than diode lasers, and hence I still prefer tubes. But in this sort of eye with the scleromalacia, a diode's impossible. And you might say a tube's impossible as well, but you'd be surprised. With careful choice of quadrant, you can find the bit where there's the least amount of scleromalacia. You can use an underlay patch of pericardium or sclera, and you can put the tube through it, so you can protect the thin sclera from the actual tube. You can then put another patch on top like the sandwich. And again, in these sorts of patients, you do have a surgical option that that you could not use any other technique, and requiring a good intraocular pressure control. There are eyes where there's just a serious risk of hypotony if you diode. Chemical burns, the external surface and avascular conjunctiva is always a worry. But my experience, the risk is that these eyes have very fragile ciliary body, and diode laser can make them crash. And again, a tube can control the pressure. There are those who you must avoid hypotony in all cases. This is Sturge-Weber syndrome, where a trabeculectomy can be done, but if you get hypotony at all, you're in trouble. And a tube that's where flow is regulated carefully can avoid the extremes that you might not see otherwise. And it's important to ignore the distractions. While the actual AV malformation of the Sturge-Weber syndrome is a distraction, these do not bleed excessively. Hypotony, that's the real risk. So you can see you can put tubes in all sorts of situations which you might regard as being crazy situations with various impediments where nothing else would work. The question is, but will actually the tube work in this situation? And that is the question, because obviously if the tube is only producing the sorts of pressures that we regard as being normal for the Multino implant, then it's probably not much point doing a tube if you're only going to get down to 23 on 2 medications. But this is the paper that caught my eye in the late 90s. This is a study out of Doheny where they found that at 5 years in a randomized clinical trial, the Barvelt 350 implant was producing cumulative success of almost 80%, with a pressure that was fairly respectable, less than 14 on an average of 1 medication. This was actually a randomized trial of the 350 Barvelt versus an even bigger 500 Barvelt was never commercially produced. But it was the 350 results that really caught my eye. These were complicated secondary glaucomas, such as the cases that I've mentioned. So with appropriate case selection, TRAVs will lower IOP more and for much longer than the alternatives. But whereas TRAVs require very careful case selection, the Barvelt implant works on almost anyone. That's the difference. You can get lower pressures with TRAVs, but only in specific situations. But the Barvelt, you can get reasonable pressures, maybe not as low, but in almost anyone. And what about the less exotic situations where the eyes are not very sick? Are tubes appropriate there? Well, there were 2 problems with the Multino. One was the poor flow control and early hypotony problems, and the second was encapsulation. And the 2 most popular implants in the market have addressed one of these 2 problems each, but neither has addressed both. The Amid valve addresses the flow problem. The Barvelt addresses the encapsulation problem. The Amid valve is medium surface area. It's got a flow restrictor. You don't get so much early hypotony. And if you do get early hypotony, it tends not to be too extreme. The Barvelt has a large surface area. It's thin. It's no flow restrictor. It's more effective than the Multino was in terms of preventing encapsulation. But you've got to be an expert at getting it right, because if you don't get the flow control right, you're in big trouble. So the Barvelt is really for the surgeon who's doing a lot of tubes, and the Amid is more for the surgeon who's doing not so many tubes, although arguably if you're not doing many, you should probably not be doing any. But the Barvelt is a larger surface area, flexible silicon, very aerodynamic, and although it's a huge plate, it has low encapsulation compared with its predecessors. You can see that the Amid valve is quite thick over 2.5 millimeters thick over the substantial portion of its surface, whereas the Barvelt is only about 1 millimeter thick over 90% of its surface. So the Barvelt's less of a lump, even though it's a very large surface area. The Amid valve, they originally claimed a Venturi flow design, but this is not really true. And the valve in practice is not 100% reliable, so some care is required. But nevertheless, for the less frequent surgeon, the Amid is relatively safe and easy to put in. Whereas for the non-valved implants that work much better, accurate flow control is more difficult. And that has really been my journey, really. If we take the starting point that the Barvelt seems to be the most effective implant, then how do we make it safe as well as effective? Because ideally we want the most effective one. We don't want one that's less effective. We want our operation to work. And total occlusion with a ligature was generally the accepted norm to manage the Multino and the Barvelt. But this technique's not satisfactory. When the ligature absorbs, the pressure crashes. And to get better pressure control, we were often adding adjunctive mitomycin. And when that ligature went, then the pressure crashed even more if you used mitomycin. So we started using an internal stent that was first described by Mark Sherwood in 1993. The Supramid, or 3/0 nylon braided stent, went all the way into the anterior chamber. And from it all the way into the anterior chamber through a tight entry site, you could actually avoid using a ligature, and then you could pull the stent out a bit at the slit lamp, just adjust it slightly, or adjust it, and if there wasn't, if there was still too much flow with the stent in, you could add ligatures surgically, and you could laser those at the slit lamp after 2 or 3 weeks, and you could provide a way of grading the pressure drop. So you could titrate it intraoperatively, look at the flow, either put the stent the whole way into the eye or part of the way in with ligatures, and you could sequentially adjust things later. And this seemed to be a better way. It's not 100% accurate, but it's a better way. The trouble with the 3/0 nylon Supramid was that there was a degree of tolerance, and some batches were too loose and other batches were too tight. The Supramid, which was the stent, their website actually published the tolerances, but I think there's also tolerance in the tube implants, and no tube implant manufacturer actually publishes their tolerance. One possible solution to reduce this variability was to stent with a 3/0 Ethlon instead. Even though the Ethlon in theory is the same diameter as the Supramid, it seemed to be looser in the tubes, and but in some cases that produced too much flow. This is more like the sort of flow that you want. And that was after the Ethlon plus a ligature. And remember that the ligatures can be lasered after a few weeks, and then you can pull the internal suture out after 3 months perhaps. So you can sequentially manage the pressure. And what's the difference between doing this more complex hassle technique than doing the original ligature? Well, it's because it's not all or none. You've got a degree of surgeon control. And for these complex patients where you're trying to get pressure control that's predictable and adjustable, this does give you some adjustment. So the surgeon maintains some control that you don't otherwise have. This is the Supramid, and I would have said that's probably a little bit too much flow, so I put on a ligature. And this is the anatomy later for the Barvelt. You've got the 10/0 nylon ligatures that you can laser at the slit lamp, and these are easier to laser than doing laser suture lysis after a trabeculectomy. You've got this blue sutures holding the tube in place. You've got the Supramid coming out of the back of the eye, and the end of it that you can then pull and adjust later. So you would, after a few weeks, you would laser the ligatures, and after a few months, you would pull the Supramid. So you can bring the pressure down sequentially, bit by bit. And these ligatures are relatively easy to see unless the patient's got extremely thin, thick tenons. So it's clearly much more difficult to get the flow right with the Amid Barvelt than with the Amid valve. So why bother? Well, we've got to look at the evidence for tubes and their efficacy. And the first evidence really was the tube versus trabeculectomy study. 212 patients randomized to a trab or a Barvelt. These were not low risk eyes, they were medium failure risk, having had either previous scleral tunnel cataract surgery or previous trabeculectomy. About 12% of the group had only had previous clear corneal phaco, but 88% had previous scleral tunnel surgery of some sort, either trab or cataract surgery. And at 5 years, the trab group was producing slightly lower pressures on slightly fewer medications, but the overall failure rate was actually much lower in the tube group. There were many more qualified successes in the tube group. In the primary TVT study, however, which is the same study as the TVT study done in 242 eyes with medically uncontrolled glaucoma and no previous surgery, no cataract surgery, no nothing, just primary glaucomas. There were 29 investigators at 16 clinical centers. And in this patients at 3 years, there were roughly 100 patients in each group. And you can see that at 3 years down the bottom here, the trab group was doing rather better than the tube group, with pressures 2 millimeters lower on less medication. And although the difference is not enormous, trabs at 3 years in primary cases were doing better than tubes. So in the complex secondary glaucoma, so those with serious previous surgery, tubes do better than trabs. In the medium failure risk patients with one failed trab or scleral tunnel phaco, the results were similar, but in primary cases, trabs do better than tubes. So there's a grade in whom you select the cases. The probability of failure at 3 years in the primary TVT study was roughly, it was almost 40% for tubes, and but it was 26, 27% for trabs. If you wanted a pressure lower of less than 15, then neither group was really going to have much more than a 50% success rate. So the failure rate for low target pressure was actually very, very similar at 3 years for trabs and tubes. But you can see overall trabs had more success than tubes. Trabs work better in primary cases that have had no previous surgery, but relatively speaking, tubes seem to work better when the starting pressure was very high. So you had a very high starting pressure. The difference between trabs and tubes was less. But that, going back to my original question, what's the difference between the tubes? So you can see that if you're looking at Barvelts, very complex cases, Barvelt works better than anything. Medium risk cases, Barvelt seems slightly better or similar. Low risk cases, trabs work better than Barvelts. But how does the Barvelt compare with the Amid valve? Well, this is a 5-year treatment outcome study in both the ABC and the Amid versus Barvelt study. 2 simultaneous randomized clinical trials, similar outcomes. Barvelt gives better IOP control. The Amid had a better safety profile. The pooled 5-year results accentuated the difference. And the pooled 5-year results showed that at 5 years, they had 170 patients roughly in each group. So it's quite a big analysis. And consistently through the study, the Barvelt produces lower IOPs on fewer medications than the Amid. And the difference in pressure and success between the Amid and Barvelt is really like the difference between trab and deep sclerectomy. If you don't need a low target pressure, do deep sclerectomy. But if you need a low target pressure, do trab. And this similarly works with tubes. The Barvelt produces a lower target pressure. And at 5 years, there was a 3 millimeter mercury difference. The Barvelts were in 13, which is really a respectable target pressure compared with 16 for the Amid. But not only that, they were on fewer medications as well. The risk of a serious complication was higher with the Barvelt. The more no light perceptions, but part of that was because on the number of neovasculars in the study, the Barvelt is not appropriate for certain cases like severe neovascular glaucoma, and because they do badly anyway, but they do even worse with the Barvelt, and they do need a smaller plate, not a 350, and therefore the Amid in severe neovascular glaucoma, 250 Barvelt or an Amid valve is probably better. Why the difference? You know, it should be possible to produce a tube that not only has a decent flow restrictor, but a low encapsulating plate. Why have we not achieved this? Part of the problem with the Amid valve achieved from this study is that it's quite a coarse surface and it attracts fibroblasts. And the Barvelt and the Multino implant are heavily polished. The Amid valve is a rough, and this is the FP7 surface topography. This is the S2. This is the Barvelt, and this is the Multino. And you can see the difference. The Amid valve is a much rougher surface area, so it provides a purchase for fibroblasts. In tissue culture, they adhere more tightly, and it's more likely to scar. However, it's not all, as I mentioned, in favor of the Barvelt. There are conditions where a Barvelt 350 really has a high risk of hypotony, and you mustn't use one. Certain types of uveitis, and such as JIA, severe JIA from childhood, patients with many CPCs, chemical burns, anywhere where the ciliary body is very badly damaged. The eye may crash if you put in a 350 bar vault. In those cases, I would often still use a single plate Multino or a 250 bar vault or an AMID valve. And the single plate Multino is still my go-to implant in eyes that are very high risk of crashing, very high risk of low pressure. The challenges with shunts, and why do people get so many problems with shunts? You know, problems like corneal damage, problems like erosion. We got to put the plate in the right place and put the tube in the right place. And remember, it's important not to compromise on placement because of the obstacles. I showed earlier a number of obstacles, and you need to have good surgical technique to get around these. These are bar vaults in the orbit, and they should be as far from the limbus as possible. They don't encapsulate and the plate doesn't erode. Aim to get the plate as far from the limbus as possible. This is correct, and the one on the right really is terrible. And I've seen this on a number of occasions, and the surgeon says, oh, well, it was very difficult. Well, you need to get good exposure, use a lot of traction sutures, get the eye well exposed with a large peritomy so you can get the plate in. I don't implant tubes when there's silicone oil fill. I do implant tubes when there's residual oil. Oil goes up the tube into subconjunctival space, and that's unpleasant. But on the other hand, they do work well even when there is oil. This was residual oil. That was from a leaky vitrectomy port many years ago. And you can see the silicone oil going up and down the tube. I think this was a Multino implant. You can see the bubble with the oil in it. This is not ideal, but it still works. This was the eye with Sturge-Weber syndrome I mentioned before. You can see the patient had a previous trabeculectomy, which is quite a hazardous procedure to do in these eyes. You've got hypotony, you can have huge serous choroidal effusions, hemorrhage, retinal attachment, and with the tube controlling the pressure and ligated, you've less risk of this. Getting the plate in, large peritomy, small conjunctival incisions are an obstacle themselves. Choose the quadrant with the fewest impediments, preferably avoiding the nasal quadrants for the AMID and avoiding supranasal for the bar vault, because the high bleb can cause double vision. Avoiding the cornea is important, but here is one, this very first tube that I put in a buccal more than 15 years ago. And question to this is the same patient a few months later. You see this lady had Stickler syndrome. She actually had nystagmus as well. And this was after a few months. But this was 13 years later. And the pressure is in high single figures. And the only problem she has now, you can see the cornea is still clear, but the tube has migrated a little close to the cornea. And the only risk now isn't from the pressure, it's from corneal damage. And it's important to avoid the cornea. This is uveitis with bridging synechia. On gonioscopy, you can see where there's open angle and where there isn't. In this eye, which had posterior polymorphous corneal dystrophy and extensive anterior synechia, you should not put the tube in the angle, because then it will be in the cornea. You need to put the tube in the sulcus, perhaps through an iridectomy. And this is a 5-year prospective study that we recently published in Ophthalmology Glaucoma and presented at the American Glaucoma Society. 64 patients completing a 5-year recruitment and study of corneal endothelial loss after bar vault implants. Now, on multiple linear regression analysis, if the tube was in front of Schwalbe's line, you had roughly a 50% reduction in endothelial cell loss at 5 years. If all of the tube entry site, and I'm talking about the entry site, if the bar vault implant of all of it was behind Schwalbe's line at 5 years, you've lost just under 25% of your endothelium. If it's straddling Schwalbe's line, it's 30%. If it's in front of Schwalbe's line, it's over 30%. And straddling if it's largely behind Schwalbe's line, but straddling it 32%. If it's more than 50%, but less than 100% anterior to Schwalbe's line, just in the very peripheral cornea, 50%. Ironically, if the tube site is all anterior to Schwalbe's line, it's more into the cornea, it's not actually as bad as if it's straddling Schwalbe's line. But the message is that tubes in the sulcus in other papers actually produce less endothelial cell loss than tubes in the anterior chamber. But if you look at tubes in the anterior chamber, tubes completely behind Schwalbe's line actually have lower endothelial cell loss than has even been published in some sulcus studies, roughly 6% a year. So this is bad, but on the other hand, we're not seeing many tubes after 10, 15 years with corneal decompensation, largely because we try and keep them behind Schwalbe's line. So, but on the other hand, this is a worrying statistic, and it's not just the tube tip, but it's actually the position of the entry site that's important. If you look inside the eye, this is a 25 gauge needle, which is actually smaller than the tube, going through trabecular meshwork. Going through scleral spur, not trabecular meshwork. So that's the ideal needle entry. And you can see if you're doing that, you're right on the iris. So more common implantation technique is just in front of iris, which looks nice, but actually look, that's right in the cornea. That's in front of Schwalbe's line. So you're doubling the rate of endothelial cell loss by doing that. So it's important to get the tube either in front of Schwalbe's line, or sorry, either behind Schwalbe's line or in the sulcus. But even in the sulcus, there is still endothelial cell loss. We found in our study that despite people's claims about inflammation, there was absolutely no correlation with aqueous flare, and half of the tubes in our study were actually uveitics. If you can sulcus fixate easily through an existing iridectomy, if it's been there from a trab, don't put it actually through the trab itself, come in from the side. An easy way to do an iridectomy to sulcus fixated tube is to take the retinal 23 gauge retinal scissors and forceps and make an iridectomy that way through 20 gauge MVR incisions. This is easier than the traditional external technique and easier than using vitrectomy, but does cost more money. If you've got this type of neovascular patient with the tube with very high PAS, you can actually sulcus fixate the tube behind the iris into the pupillary margin. Be careful with sulcus fixation because you can hit the edge of the lens, as you see here, then the tube's going behind the implant into vitreous cavity. So you've got to not do that. You've got to make sure that the tube is actually in front of the lens implant. And with sulcus fixation, it's better to make the tube slightly longer so it doesn't get deflected behind the implant into the vitreous or behind the lens. If you've got a very small eye, such as non-ophthalmic, put the tube in the pars plana. This is pretty much the only situation where I use pars plana other than patients that have multiple erosions. And despite, you can see that this patient, despite a vitrectomy, there's still vitreous base catching the tube. And the problem with pars plana fixation is that you really need a very good vitrectomy, shaving vitreous base. And even if the patient's had a previous vitrectomy, you still need to do another one. I strongly advise avoiding pars plana modified implants. Even with proper patching, these erode easily. You must, because basically a plastic plate at the limbus is a bad idea. The Amid valve has a similar modification, and I would say do not use these. These are bad. What do you do with aphex? How do you keep vitreous out of the tube? Well, you keep the tube ideally in front of the iris, so it's not it's as far from vitreous as possible. Keep it away from any iridectomies. Avoid disturbing the vitreous, and do a vitrectomy if you have to, but you'll be aware if it's an aphakic eye full of vitreous and you take out a little bit of vitreous, you end up taking out a lot of vitreous. If you've got a lens implant such as an AC lens, you can put the tube in front of it, and it's worth leaving the tube a little longer so it doesn't end up close to iridectomy and getting vitreous. But overall, as you'll gather, tubes do have problems. Corneal endothelial cell loss is annoying. Tube erosions are annoying. And why have we not conquered this? Now, here is a short video addressing the problem. The Barval is the most effective implant, but it's very large. This is a Zen implant. It's tiny. This is a PreserFlow microshunt. It's also tiny. Why do we use such huge Barval implants? Well, we use such huge Barval implants because the very aerodynamic biocompatible plate works much, much better than any MIGS device. But the tube doesn't need to be so large. And both the AMID and Barval have large tubes which erode and cause corneal damage. They occupy almost the entire drainage angle and must rest on the iris to avoid cornea. If they're in contact with cornea, their entry site, even when lying flat, you can see Schwab is lying just about in this video. Tube contact with corneal endothelium, as we know, kills endothelial cells. And a large tube in the scleral surface will always carry a small risk of erosion, even if you use a patch, even if you use a long tunnel. These all eliminate the erosion risk, but do not, they reduce it, but do not eliminate it. How do we reduce the erosion risk? Well, even these small implants like the Zen and the microshunt do carry a small erosion risk, but it's a lesser risk. These smaller tubes, and you'll see in a moment how the Zen and the PreserFlow can produce a large IOP drop, but they still can erode. They're just not as effective as a Barval at controlling the pressure and cannot be used in more complicated cases. Even the Trab is more useful. See here how much larger the Barval is. It's bigger almost than these two Zens put together. The PreserFlow can fit inside the Barval. It's a tight squeeze, but you can actually fit it inside. So why, if the plate is the factor that determines the encapsulation, why are we using these large tubes? As you can see here, even the PreserFlow can erode, but this is pretty rare. It happens in less than 1% of cases, and probably the same with a Zen, and that's an exposed Zen. The erosion rate with a Barval or an AMID valve without patching would be something like 13 or 14%. With these, without patching, it's about 1%. With a Barval, it's down to 2 or 3% with decent patching, but without patching it would be 13 or 14%. So these smaller tubes likely carry a much smaller risk of endothelial cell damage because of their size, and they're less likely to erode. The trouble is they don't work as well as the big tubes because of the plate. But the big tube, the Paul Glaucoma implant was from Singapore, is a smaller tube than conventional implants and similar plate characteristics. So this big plate has similar tube size almost to a PreserFlow. So in theory, it should cause less corneal damage and less erosion. This is new and it's yet to be proven. But compare the tube size of the pole with a Barval and the PreserFlow. It's not as small as the PreserFlow, but it's a lot smaller than the Barval. So what we really need is to take a little bit of inspiration from the MIGS, and the large plate tubes need to maintain the plate size for efficacy, but the tubes need to get smaller because they don't need to be anything like as large. And this is certainly one way forward for tube surgery, and it offers one light at the end of the tunnel in my journey to get implants to be more efficacious. And here's a Paul Glaucoma implant in the eye, and this is occluded with a 6.0 proline, which is much smaller than the 3.0 we use for the Barval. And you can see this little well. We can gauge the flow, and we can get an idea of what flow there is and adjust the proline to permit slow flow. And this is obviously still requires some expertise and skills. It's not as easy as a MIGS, but it's a lot more effective, and it in the more complicated cases, and it seems to be similar in efficacy to the Barveld. And this has recently been published in Ophthalmology Glaucoma by a group of us. So it's technically possible to implant a tube successfully in various situations with various implants. There hasn't been very fast evolution of glaucoma surgery, except in the MIG space, but we are getting there. And these more difficult cases need the same attention as the MIGS cases, and they need better implants too. But evidence suggests that tubes can work well. Thank you for your attention. And I think that concludes this lengthy, passionate discourse on how valuable tubes can be in glaucoma surgery. And thanks for the kind invitation.
Thank you very much, Keith. That was truly a wonderful journey, and there were many things that often we don't think about that you have described. And I think before I go on to asking you a few questions, Prabhat, can you just check if there are any questions that people have asked? Are there any so far?
Not yet. We're waiting for the questions.
All right. So you rightly pointed out. Yeah. You rightly pointed out that sometimes with the Ahmed glaucoma valve, the complications are much less, but you're often unable to predict that the intraocular pressure is going to be in the high teens, and often it's not. And what you described is so classical that you end up having a pressure of 21, 22, 23, and the patient is on 2 medications to reach that pressure. Yeah. Do you think that this is the character of the Ahmed's glaucoma implant, or do you think that surgically there may be something that could be done in the way that you operate to get better results?
It's a little bit of both. My American colleagues will say that the problem, the Barveld enthusiasts in the United States will tell you that the problem with the Ahmed valve is that you get aqueous flow early on, and that's got the TGF beta that stimulates fibrosis. That's partly true for sure. But on the other hand, the Ahmed valve plate is not designed with biocompatibility in mind. It's designed with flow control in mind. And it's not perfect at flow control, but it's pretty good. The Barveld is designed with compatibility in mind. If you look at it, it's a very elegant surfboard. It's very big, and the surface area, everyone says, oh, well, the Barveld's a big surface area. Well, that certainly helps for sure, but it's also got no square edges. It's perfect. It's all curved. It's highly polished. The fibroblasts don't stick to it. So there's a number of features. Yes. And you imagine the eyeballs moving all the time, and it's rubbing against the tissues all the time. And if you have something that's got no sharp edges, it stimulates less fibrosis. If you have something that's smooth, fibroblasts don't stick to it. So there's a number of simple modifications that would actually improve the biocompatibility of the Ahmed valve. Without the flow control would still not be perfect, but it'd be better than the Barveld at the minute. Yes. You may not completely get rid of the encapsulation problems, because you do have early flow, and that probably does stimulate, some encapsulation. But I think some of it is just biocompatibility of the plate.
So that leads me to the next question, that if you were to paint mitomycin to the undersurface of the tenons, way behind where the implant is going to be placed, would that reduce the degree of the encapsulated, the fibrous blebs that you tend to get in association with Ahmed's glaucoma valve?
There have been studies of the Ahmed valve with mitomycin, and no one's been able to show a benefit. Ironically, we actually use mitomycin with a lot of the Barvelds, because a lot of these patients, you're really just desperate to get the pressure down to 10 or 11 or 12. And if the mitomycin will do anything, we actually, with the Barvelts, we use much higher levels of mitomycin than we would with a trabeculectomy. And it's put way round at the equator. And we're using 0.5 milligrams per mil for 5 minutes on a big sponge. Peng Ko, my colleague, and I've copied him a few times, even uses 1 milligram per mil for 5 minutes, because simply the evidence is that mitomycin doesn't work. But in some cases, we're really pushing the boat out. We're trying so hard to get the pressure down that we do use it. But the evidence is that with AMID valves, it doesn't work.
All right. Okay. So, Dr. Pandav, would you like to ask a question before we go on to the audience questions?
Yeah, sure. I think, Keith, you mostly prefer BGI like 350 square millimeter surface versus 250. Is that correct? I mean, so is there any, what is the kind of a relationship? Is it possible to get the desired effect just by changing, choosing a valve which is a different surface area?
Well, in theory, it was always assumed that the Barvelt worked better than the AMID, because the 350 was much bigger than the 184. There hasn't been really hard evidence of a difference between the 250 and 350. If you look at the bleb characteristics of the 350, all these blebs are quite fibrosed around the edges, but in the middle they're very attenuated. And my feeling is that the 350 gives good pressure control because the very stretched bleb is more attenuated in the middle. And my suspicion is that the 250 wouldn't be quite as good. So I've never used it. Well, I have used it. I use it in cases where I'm worried about hypotony. The pole glaucoma implant, interestingly, is not quite as aerodynamic as the Barvelt, but it's a 340 millimeter plate, and it's more circular. It's and less under the wings, less wings under the muscles, and it seems to give pressure control very similar to Barvelt as well. I think if you have a large distance between the edges of the plate, this is purely my opinion. This is not scientific evidence, just from my observations. The very middle of the bleb seems to be thinner and more attenuated, and I think that's the bit that counts. So if you have a smaller plate, you don't get that thin bit in the middle. So it's not actually. So I think that's why the surface area matters. That's pure opinion from cutting open too many of these things.
So, I think it's not only the surface area, the edge profile seems to matter.
Yeah. The other thing you asked was surgical technique. I think the one thing that's important about surgical technique is getting the plate way back, making it 10 millimeters from the limbus and not 6 or 7. The worst, most scarred AMID valves I see are when someone's put it in and it's migrated forward, or they haven't stitched it and it's slid forward a little bit, or it's just pushed its way forward, and they're very, very scarred because they're only 4 or 5 millimeters back. If you can get them 9 or 10 or 11 millimeters back, in general, I think they work better. But again, that's pure opinion, an observation.
Can we take a question from Dr. Kashinath Sinoy? He's asking, how will we manage bleb encapsulation and the hypertensive phase following the glaucoma AMID implant after 4 to 5 weeks?
The AMID valve hypertensive phase, I think the current wisdom is that you just use a lot of aqueous suppression. The theory being, if there's aqueous stretching the fibroblasts, then they scar more. And if you can use, COSOP, diopidine, anything to suppress aqueous flow, Diamox, just get the aqueous flow down, then you reduce the stretch on the bleb, and that reduces encapsulation. But this is an age-old discussion that people have been having.
I wanted to ask you that some of these patients that develop the hypertensive phase, is there a suggestion that some of them may not come out of their hypertensive phase actually?
Well, the cynics, the skeptics would say that the hypertensive phase really is just the start of failure. Once they're getting a hypertensive phase, they don't get better again. That's not exclusively true, but you know, it means the capsule is developing. Obviously, capsules evolve, and you don't have mature collagen at 4 or 5 weeks. But a lot of people will say that, you know, the hypertensive phase is the beginning of the end.
Keith, do you ever excise these capsules? You know, these thick capsules, and do you get pressure control after that?
I have tried it, you know, and most people who do this will say that you excise it. Firstly, you get hypotony. If you do it with a barbell, you get hypotony, and then it regrows again. And the Amid valve, you've got the valves, you don't get hypotony as much, but they all say that even if you excise it with mitomycin, it just grows back again. I must say, if I get a scarred Amid valve, I usually remove it and put in a lot of mitomycin and replace it with a barbell further back if possible. And in general, that works. And if I have one barbell that's working, if I have one barbell that's not working enough, then I will put in a second one, usually one supratemporal and one infranasal. With a barbell, it's unusual to get a barbell that doesn't work at all. You know, it does happen, but in general, you get one and it's reduced the pressure a bit. You know, the pressure is 40 to start with, and it's come down to 25, but 25 is not low enough. But it's reducing it from 40 to 25, so that's pretty good. If you put in a second one, you might get it from 25 to 15, and that's in general what I will do. The problem is if you've got one where it's still 40, where it's unusual, then what do? It's really diode laser. You can excise the capsule, or you just give up and put in another one with a lot of mitomycin, but that might not work if the first didn't work.
There's a question from Dr. Alka Pandey, and she would like to ask, how do we deal with early opening of the ligature suture in the Behr-Wills implant?
Well, I don't, yeah, this is why I don't use the ligature, especially if I'm using mitomycin, because if it opens it, they open it about 5 weeks. And the pressure goes, you know, and if you've used mitomycin, it really crashes. So that's why we keep the stent suture inside, because it prevents the crashing. First thing I do is viscoelastic at the slit lamp. I'll put in a small amount of Helon 5 or just to protect from the low effect, and then wait and see if the pressure comes up again. But the problem is that it's not really safe to have an unguarded tube until about 3 months, and the ligatures go at 5 or 6 weeks. They go too soon, and that's one thing I don't like. And if the ligature would absorb at 3 months, that would be perfect. The risk would be very low, but they absorb at 5 or 6 weeks, and then you need some kind of backup plan. And my backup is to have a stent suture inside to prevent hypotony.
I think we have more questions coming up, and there is a question that that is asked by Dr. Himangi Rathi, and she asks, what is the efficacy of Ologen with when used with Ahmed glaucoma implant?
There's no evidence to date that Ologen is effective when used with anything. Ologen scars. It certainly with the studies with filtration surgery is that it's of no benefit, if not negative benefit. I know it's popular, but the evidence is very negative.
Yes. There's a question by Dr. Krishna Das, and he would like to ask, how do we manage late hypotony with the Behr-Wills glaucoma implant?
That's another talk. I've got a lecture on that too. So the typical thing that people do is go in and ligate it. The trouble, and this is another sort of challenge on my journey, is you know, if you ligate it, the pressure goes from 0 to 30 again, so you're back to square one. What I do is I take a small piece of Ethelon or Supramid, 10 millimeters. You go into the anterior chamber and you push it up the tube. Why do that rather than ligate? Well, because if you ligate, again, your pressure goes up to 30. Whereas if you take a small piece of nylon and feed it up the tube, that can bring the pressure from 0 to 7 or 8, or from 3 to 10. You know, it's a much gentler way of bringing up the pressure. The biggest problem with glaucoma surgery is overreaction. You know, we have a trab and the pressure's too high, so we take out a stitch and the pressure's 0. You know, we have a tube and the ligature goes and the pressure goes from 40 to 0. It's the overreactions that are the problem. And then we go in when the pressure's low and we put in a stitch and it goes too high again. And the challenge is to avoid it going from too low to too high. So the gentlest way is literally put some viscoelastic in the anterior chamber, take a small amount of Ethelon or Supermid, 10 millimeters I usually measure it and cut it and just feed it up the tube from the AC. It's actually not that difficult to do. And then remove the viscoelastic. And that way you can reduce the flow through the tube without closing it completely. And they get rid of the hypotony. If that doesn't work, then ligate the tube. But most of the time that will get you out of the trouble.
Dr. Surinder, can you continue with the questions that the audience is asking? There are a few more questions.
Let me see if I can see them.
I'm
not getting the questions.
No, it's there. You have to click on the
okay.
question. Yeah.
Okay.
So, okay, there's a question by Dr. Alka Pandey. Sorry, did you get it, Surinder?
No, I'm not getting all of them actually.
Okay, so there's a question by Dr. Alka Pandey, and she says, would a pediatric Ahmed glaucoma implant be better in eyes with previous scleral buckle?
No, that's I mean, why the pediatric one? Because that's got no surface area. That's a very poor implant because it's not going to work. The point is, eyes with previous scleral buckle scar heavily, so you need the lowest scarring implant, which is the biggest one. It's like the pediatric one, to be quite honest, isn't even good for pediatrics, you know, because children scar a lot. So having a smaller plate makes no sense. They're going to scar it. You might as well not bother. You know, you need to have the least scarring implant. And the pediatric Ahmed arguably is the most scarring implant. You know, so that's going to work less well in a trabeculectomy.
There's another question from Dr. Shilpa More, and she's asking whether you've had some experience with the Adi valve.
Yeah, I apologize for not mentioning the Adi valve. We actually set up to do a randomized clinical trial in Ghana a few years ago, but because the Adi valve was not CE marked at the time, Moorfields wouldn't support the study, so I wasn't able to do it. We have put a few in, the Adi is basically a clone of the Barvelt. It's a little bit floppier. It's not quite as smooth, but it's basically a clone of the Barvelt. I've seen data which looks reasonable, and I've seen some studies that don't look so good, but I'd be interested if anyone in India, maybe you've got more, maybe you have experience with it and I don't, so I'd be interested if anyone's done a lot of both Adis and Barvelts and seen what the difference is.
We have Dr. Krishna Das. Is it possible, Prabhat, to have Dr. Krishna Das talk a little bit about the Adi?
Yeah. I'll just request him to join.
And also, please type the answer.
Dr. Krishnadas, good afternoon and welcome. He's just joining.
Krishna, are you there? Dr. Krishna Das is a Chief Medical Officer at Arvind, and we're just trying to get him on board so that, you know, we may be able to listen.
I'd be very interested in anyone who's done a lot of Adis to hear their
experience. Vinay, can you hear me now?
Yes, we can hear you. We can hear you.
Yeah.
Please go ahead,
Thank
Krishna.
you.
Welcome on.
Thank you, Vinay. Thank you, Vinay, Surinder, and Dr. Barton. What a great talk. I really enjoyed listening to him. Yeah, just being specific about the RD, I have used a few barbells about 10-15 years back, and I use lots of AGVs and a few RDs. And as far as the, he rightly said, it's actually engineered based on the Barwelt, and we actually have Dr. George Barwelt himself look at RD and appreciating the design. We had actually his permission to go ahead with the manufacturing and marketing RD in developing nations. As the user of both, I personally don't find a large difference between Barwelts and RD. And some of our colleagues, senior colleagues in the US, like Dr. Mark Lieberman, who have had the opportunity to use a few RDs, exactly made the observations which Dr. Keith Barton had said. They are more flexible and floppier, and the surface is not as polished as Barwelt, and these criticisms and feedback have been taken into account, and ROLab has been actually improving the design. As far as the results, we have a few publications, both from Aravind, from PGI, as well as from LVPI, and they don't seem to differ a lot in terms of, actually we have not compared directly RD and Barwelt. So going just by the retrospective results, we feel the efficacy and complications are much comparable to what the Barwelts is given. So it's a very good alternative, especially in communities like India and other African communities where Barwelt could be more expensive. Thank you, Vinay, and thank you, Keith, for that wonderful talk.
Pleasure.
Thank you for being with us, Krishna.
I have used RD and AGV. I haven't used Barwelt. I think like Barwelt, the RD tends to give you a lower IOP as compared to the AGV, and like not have that hypertensive phase, those kind of things. So I think the results are kind of in line with what we see with Barwelt implant and RD. We don't have any direct comparison of the two. So like Krishna said.
One of you is a corneal specialist. Did you say at the start? Did you say at the start?
Prabhat, are you on? Prabhat?
Yes.
Yeah, Prabhat is a cornea specialist. Prabhat?
Yeah,
go ahead.
What do you think? Corneas in tubes.
Sometimes you have to use them, particularly in cases where, if you don't have the angle structures stable at all, and you've had 360 synovial closure post graft, particularly in cases where you've put a large graft like eyes that had to undergo a therapeutic graft, you would probably look at a sulcus or even a PPV implantation. So, those are the indications from the cornea point of view that you would have to consider a valve, and there would be no other alternative. We often ask our glaucoma colleagues retrospectively, couldn't you have placed it a little bit closer to the iris so that we wouldn't have to deal with that localized decompensation and, close follow-up of the patient. But I think, as long as the pressure is lowered, we can just follow up and just keep a close watch at the endothelial health.
We have been, the reason I asked was that although corneal specialists in general are not keen on tubes, partly because glaucoma specialists do put them too close to the cornea. I think it's not just the tube; it's actually where people are putting them. But our corneal specialists, we're obsessive about keeping the tubes against the iris. And then someone sends me a referral saying there's a problem with this tube; it's touching the iris. I said, that's where it's meant to be. And they're telling the patient there's a problem with the tube because it's touching the iris. And I say, if it's not touching the iris, then it's in the cornea. There's no other way. Yeah, but what interested me was our corneal specialists about 15 years ago would start sending me patients and say, I want to do a graft in this patient, put the tube in first, get the pressure sorted out, then I do the graft. And that seems to be the least traumatic way. So we do that a lot.
Yes, I think, in the early post-operative period, we're worried that the IOP might fluctuate if we do a simultaneous procedure and we might lose the graft. But in some cases, there is no alternative than to go ahead with a combined keratoplasty and Ahmed valve. And in our limited experience with such cases, we have seen reasonably good success rates. So combined procedure is an option.
We would do the tube first and then do the graft a few months later.
That would certainly be better, but there are certain instances wherein you have absolutely no view of the anterior chamber whatsoever, and so you really don't know where to put the tube. So personal preference would also be Ahmed valve first, or any valve procedure first, and then the graft once the IOP has stabilized. But if that is not an option, then we might want to go ahead with a combined procedure.
We have a question from Dr. J.C. Das. Dr. J.C. Das is one of our colleagues and also the former president of GSI. He would like to ask that he has seen 2 cases of anterior segment ischemia after Barewell's valve surgery, Barewell's glaucoma surgery. Do you have any opinion about this? Is this something that you have seen?
No, I've used Barwell's for anterior segment ischemia, but I've never seen any case. Patients with because sometimes anterior segment ischemia patients have not very much inflow because of the ischemia, but they've no outflow. It's like uveitis where there's not much aqueous production, yet the pressure is very high. So I've used tubes, but I've never seen a tube cause anterior segment ischemia.
Okay. Is there, sorry, Surinder, you were saying something?
Yeah, I'm just wondering, is the iris seems to be more tolerant to the tube touch. So do you get ever concerned if your iris is tube is touching the iris?
No, not at all. I put them deliberately touching the iris to avoid, because you've got to minimize corneal contact. And it was my friend and colleague Graham Trope in Toronto used to always say that tube touching the iris causes uveitis. It doesn't. It really doesn't. My practice is 50% uveitic glaucoma, and my tubes all touch the iris. And we looked at this. We looked at that prospective study of the corneal endothelium. We looked at flare. It didn't seem to make any difference.
So while on the subject of, sorry, go ahead.
Where patient developed cystoid macular edema. So I was wondering whether this is because the tube touch, or it might have happened otherwise also.
People always speculate the tube's touching the iris, but I don't think tube touching the iris makes that much difference. It causes a bit of depigmentation. If you have a patient with ICE syndrome, ICE syndrome, if the tube's touching the iris, often the membrane will contract a little bit, so you end up with a peak at the tube. So that's one thing. Or you can end up with depigmentation with the tube in the iris. But I've never seen uveitis or any other uveitis-related complication from that. So I don't think so. And we have looked at flare. It doesn't seem to make any difference.
So I just wanted to ask you that, if you have these uveitic patients with elevated intraocular pressure and persistent uveitis, after reducing the intraocular pressure with the glaucoma implant, have you noticed that the uveitis tends to decrease and not be as aggressive?
Yeah, I don't know. You may not recall Wendy Franks, who was my retired colleague, who was also another product of Roger Hitchings. Wendy used to say, when you get the pressure down, the uveitis gets better. And obviously, treating a trabeculectomy is not a treatment for uveitis, but certainly the uveitis seems to get easier to control. Obviously, if the pressure's 13 after a Barveld implant or a trab or whatever, the uveitis specialist can use as much steroid as they like, and the pressure doesn't go very high. So there is that advantage. But it's funny you said that. I remember Wendy always saying to me when I started, you treat the pressure, the uveitis gets better. Well, it does a bit.
All right. Is there anything else?
You referred to PTVT study.
Yeah.
Hello.
Yes. Is that Krishna? Hello. Sorry.
That was Surinder. I think that was Surinder.
Oh, Surinder, yeah.
Yeah, I'll wait for you afterwards. Krishna first.
Was there anything, Surinder, Krishna?
Okay, all right. Okay. I'll ask. Keith, you refer to the primary TVT study, and you said like in the primary surgery, the trabeculectomy seems to better than primary tube. So
Yeah.
was that in some way a surprise to you, or you expected that?
Well, you know, for a while, I never liked doing trabeculectomies in high myopes because, you know, the pressures go very low and they get wrinkly macula. And so for a while, I did primary tubes in high myopes or myopes. And it was my impression clinically that they weren't getting as good target pressures as the trabs. And then the primary TVT study, I guess, showed what I was starting to find in the patients. It's interesting that, and this is an interesting thing, why do tubes work so well in those really nasty cases, but in healthy eyes, or certainly healthy eyes, they don't seem to work so well, or trabs work. It's not even that trabs work a lot better, it's tubes really don't seem to work as well. And part of it, Steve Getty, the chief investigator of the primary TVT study, really agonized over this because he didn't believe it. He thought tubes were just wonderful. And they eventually found the one risk factor was that if there's a high starting pressure, tubes seem to work better. And if there's a low starting pressure, they don't seem to work as well. You know, we don't know enough about this yet, but clearly, I think part of it is that possibly maybe eyes that have had vitrectomies and retinal buckles or scleral buckles and multiple surgery, maybe there's less aqueous production or something that we, you know, and that's never been characterized. And maybe eyes that have had no previous surgery have more robust aqueous production. And I just don't know.
Thank you.
So I think we've had a great session with you, Keith, and I'm glad that we persevered and we got you on board. And thank you so much for being with us.
Certainly, it was great fun. Not as much fun as coming to India, but nevertheless great fun.
Okay, we'll wait for this to get over, and then we'll have you across in India too. Actually,
thank you so much.
Thank you very much. All of you, all the attendees, and Professor Keith Barton and Surinder and my colleagues, Dr. Sarang and Prabhat, and thank you very much, Krishna and JC Das, for being with us. That was tremendous to get you on board during the webinar, and we look forward to meeting all of you next month with another faculty to take us through some more exciting times. Thank you very much, Keith.
Pleasure. Thank you so much.